Hello, it's Jeanette Kessel speaking. I'm a board member of the AVBA, and I've been asked today to welcome Dr. Graham Swinney, who's our speaker this evening for the webinar. Before we introduce Graham, I'd like to just make sure that everybody knows about the conference in Melbourne that's coming up. The AVBA conference is in Melbourne from the 8th to the 10th of October. I'll be going, and at the moment there's a 2-for-1 registration. So that's happening until this Friday. You need to book before this Friday to get your 2-for-1 registration, which I think is a really good deal. So I'm bringing down my practice manager, and yeah, it's going to be a really terrific conference. At the end of this webinar, there's going to be a short 5-question survey to complete after the webinar, and we'd really appreciate you staying and providing some feedback. Thanks very much. Now, I'd like to introduce you to Dr. Graham Swinney, who's a specialist canine medicine and internal medicine consultant. Graham graduated with a Bachelor of Vet Science with honours from the University of Sydney in 1987. After he graduated, he taught small animal medicine at Massey University in New Zealand. In 1991, Graham returned to Australia to begin his residency in small animal medicine at the University of Queensland. 2 years later, he was appointed registrar and then promoted to senior registrar in small animal medicine at the University of Sydney. In 1998, he was awarded a fellowship at the Australian and New Zealand College of Veterinary Science, specialising in canine medicine. From 1999 to 2005, Graham taught at the Washington State Uni USA as a clinical assistant professor in the small animal internal medicine department. He practiced for 4 years as a private specialist at the Vet Specialist Centre in North Ryde. Towards the end of 2009, he joined the University Veterinary Teaching Hospital as a canine medicine specialist and hospital director. In 2001, Graham joined IDEX Laboratories as an internal medicine consultant. He has a particular interest in different aspects of small animal internal medicine, including endocrinology, gastroenterology, and nephrology. He has publications authored in journals such as the Australian Veterinary Journal, Australian Veterinary Practitioner, and Veterinary Surgery. Graham is a member of the Executive Committee of the Australian Small Animal Veterinary Association and an invited speaker to conferences. He is the recipient of the John Holt Distinguished Service Award from the ASAVA and a Westcott Clinical Teaching Award from Washington State University. So lots and lots of wonderful qualifications, and I'd like to hand you over to have a listen to Dr. Graham Swinney. Thank you, Graham.
Thanks very much for that, Jeanette. Now, I'll apologise to everybody up front. I'm on the tail end of the flu, so I'll try and cover up the microphone if I'm coughing, but I apologise for that up front. Now, as most of you are aware, I'm not a practice manager, so I'm more a clinical internist. So what I'm certainly not going to be trying to teach you about practice management this evening, but trying to talk to you about some aspects of medicine and some new things with clinical pathology to sort of bring you guys, give you some sort of basic knowledge with that. And really using that to try and give you some strategies for using clinical pathology in your practice as a tool to improve the standard of patient care, help increase that bond between you and your clients, and benefit your practice with that. So we'll very briefly touch on the standards of care with that this evening. And then some of the presentation is going to be talking about reference intervals, something that we all take for granted when we get our pathology results, but looking at some different ways that we're looking at using those these days. Briefly talk about sort of VetConnect Plus, and this is not trying to make it IDEX-centric about this, but using a sort of tool to use your results better to try and both within your practice and also for patient care, and then just sort of running through some things at the end on pre-anaesthetic testing and some different bits and pieces with that. We've changed the way we sometimes look at our results, and I spend my day speaking to people on the phone, helping them interpret results and things like that, and I get them get results in very different ways. You can see on the left a more sort of traditional or sort of older way of getting the results, and then on the right you can sort of see VetConnect Plus there, which presents the results in a very different way, but does increase the utility with that. I hope that you're all aware of the standards of care that were produced by the AVBA and the AVBA a couple of years ago. And what it was done is to be produced not as requirements for practice, but for guidelines to give people an idea of what can be done in consults at different stages of life and things like that, and encompasses a wide range of areas. There's going to be, I believe, another presentation on that in this series, so I'm not going to sort of talk about them specifically in this presentation, but if you did want a copy of those, if you haven't seen them, the AVA or ASAVA certainly have those available, and they're available online. So now moving on to some of the medical things with the presentation, and one of the sort of primary aims of the talk tonight was to talk to you about reference intervals. I suppose it's one of those things, and always a little more difficult than a webinar. I can pose the question to you, are you aware of how they're created? Obviously hard for me to see a show of hands when we're doing a webinar with that. But it's, I suppose, as I alluded to earlier, the reference intervals are something we tend to take for granted, that we see them, they're there, and we put a lot of faith in them. But we need to be aware of their limitations. The general way that you would create a reference interval for an analyzer, be it a reference laboratory analyzer or for an in-house analyzer, and obviously if it's an in-house machine, it's something that the manufacturer of the analyzer will do, is you need a reference population of patients. Ideally, that should be at least 120 patients, or animals, shouldn't really be patients with that, but 120 animals. Of the species you're looking at. Ideally, they should be a wide range of ages. They should be a mixture of different sexes, and a different range of breeds in that. It would obviously, the simplest way to do it would be like, if you're trying to do it for cats, to go into a cattery and bleed a large number of cats, or into a kennel or something like that. The challenge of that is you're often using maybe a single breed, or a narrower range of age of patients in that situation, so that can be more limiting. So generally you want to do it with a broader range of patients. Those animals in the reference population should be evaluated based on their history and a clinical examination to establish that they are healthy, because clearly when we're setting up reference intervals, we want to do that on healthy animals, to try and set up that reference range. Now, it sounds relatively, well, it's actually not simple, but, to get 120 patients can be a challenge in itself. But it's not just necessarily a case of, we'll get, 120 blood samples from a bunch of different dogs and cats to set that up. The samples all need to be collected the same way. So have a very standard protocol of using, same size needles and syringes, collecting it from, they're all collected from the jugular, for example. They need to all be collected into the same type of anticoagulant tubes or plain tubes if you're using serum for chemistries, and a standard volume used in all of the tubes. The samples all need to be handled the same way. So, spun down within a certain period of time. If we're looking at serum chemistries, the plasma or the serum harvested from that, they all need to be stored the same way. So, and ultimately when the processing is done, all those samples need to be run on the same machine at the same time, with there having been a standard sort of quality control run, calibration done on the machine, a single set of reagents used for it, and ideally the same person processing them. And that needs to be done twice, to ensure sort of consistency of the results. So it's quite a substantial task to get that all done. Once we've set up that reference interval, the general rule is if you've got a normal distribution of those results, so they fit nicely onto a bell curve, you take the central 95% of those results. So you remove the top 2.5%, you remove the bottom 2.5%, and that gives you your reference interval. So then it comes to the question of the interpretation of results compared to that reference interval. Does a result within that reference interval always mean that that patient is normal? And I'm sure, all of you listening to the presentation are experienced practitioners. We know that's not always the case. A great example of that would be, for example, if we're looking at hematology and you have a patient that maybe has hypoadrenocorticism, and you might have a perfectly normal leukogram in a sick patient. And maybe in that situation, normal isn't normal because you would expect that patient to have a stress leukogram. So the absence of that doesn't necessarily mean that they're healthy. Another example would be, let's take the example of serum creatinine. If you have a patient with a normal creatinine, it's very tempting to say, oh, kidneys are all good. But if that's a patient, creatinine is influenced reasonably heavily by the patient's muscle mass. So if you have an older, unwell cat or dog that's lost a lot of muscle mass, a creatinine at the high end of the reference interval isn't necessarily always normal, because if they had a normal muscle mass, that creatinine would be a whole lot higher. Then if we look at it the other way, does a result outside of the reference interval necessarily mean that that patient has an abnormality in that area? And the answer to that is also, it's not always the case. We've said in the setting up of those reference intervals, the top 2.5% and the bottom 2.5% of that reference population, that those results get put outside the reference interval. So sometimes, you might have a value in an individual patient that's outside the reference interval. Again, we'll go back to that example of creatinine again. You might have a heavily muscled patient like a Staffy or something like that, but its creatinine is going to run a little bit higher than the reference interval, and that's just because of the dog's body type. Sometimes we can look at how far a result is outside the reference interval. If something's 1 or 2 points away from the reference, we might be less alarmed by that than if it's significantly outside the reference interval, either above or below. So that's something to take into account as well. And if we play the simple law of sort of mathematics and things with that, if you do 20 tests on a single patient, you're getting up to a 50 or 60% chance that you might get one value outside the reference interval. And that doesn't necessarily mean that the patient has an abnormality. It just means that, they have some variation with their results. Another important thing to remember is that, there is some overlap between results in a patient in health and a patient in disease. So, the reference intervals, whilst they're really important for us to use, are not necessarily sort of the be-all and end-all of interpreting laboratory values with that. One thing that they've become, that they've sort of made more progress or earlier progress in human medicine is looking at biologic variation. And that is, the variation you can get in results from time to time or between patients or things like that. In human medicine, the awareness of this is significant. So there are different sets of reference intervals set up for different groups in the population. So with varying age, You might get different reference intervals for different, maybe different between men and women, maybe different between people of different races. So, we get a little bit more individualization of results with that. I'm going to pick dogs here specifically. We have a massive variation in our patients, that we deal with, yet we expect the reference intervals, a single set of reference intervals, to cover that. So, different ages can affect results. These two pictures, and no one here is to laugh, these are my two dogs. On the left is when they were sort of around about 6 months and 2 years old. They're getting older now. They're 13 and 11. We expect the same set of reference intervals to cover them at different times. We have massive differences in the phenotypic variations in our patients. So we expect, the little lap dog to have the same, to fit into the same reference intervals as, a dog that's, massively different in size and body type. We can look at a single breed, where I worked in the States for 6 years. It was a sort of somewhat, not a city area, shall we say, out in the country, and we had lots of what I referred to as the hunting dogs. We saw lots of them that used to get inhaled foreign bodies and would end up with pyrothorax. So as a medicine person, I learned pretty well putting in chest drains in dogs because we saw lots and lots of dogs with pyrothorax. But you will see hounds that are, very fit and active dogs because they're regularly hunting. We compare that to some of the hounds who potentially live a much more sedentary lifestyle, yet we still expect the same set of reference intervals to cover them. Another good example would be greyhounds. We do have slightly different reference intervals for greyhounds as compared to, our more standard breeds of dog. Yet we apply that same set of reference intervals to a racing greyhound as we do to a retired greyhound. So I suppose what I'm saying to you with that is we are expecting a lot of the reference intervals that we use. Now, so we talked about the biologic variation before, which is that individual variation, and that can vary from analyte to analyte. So, if you repeat something a number of times, we might get some variation with that. And there are a number of things that can cause that variation. It can be a pre-analytical variation. So, it might be, let's compare the blood sample you take from, you get a sort of, a big old relaxed Burman cat in that's sort of pretty chilled out while you're taking its blood sample, and it's all fairly simple. And compare that to the very stressed cat that you're having the wrestling match with to get the sample from, and you can only get a small amount of blood, so you only half fill each of the tubes. It's been difficult getting the sample, maybe there's more hemolysis. So things like that can affect it. Even, the difference you might get between, you take the sample, you're sending it to the reference laboratory, it gets picked up. You take the sample not long before the courier comes, it gets picked up, it goes out to the reference laboratory, and that sample is processed within 2 or 3 hours of collection, as opposed to the sample you take that gets collected just after you've missed the courier. It sits there all afternoon into the evening, goes to the lab and gets processed overnight. There is going to be some variation potentially in results with that time difference. The analytical variation can be, it may be the same machine that you're using, but, different reagents, yes, they get calibration and QC done every day on them, but, there can be some variation with that. Or even, it may be a different machine in a different lab that's being done. You can also get variation between different individuals and even within an individual with blood taken at different times. So there's been some work done recently in a couple of different places Craig Ruau, who's a Queensland graduate, who now is working at Oregon State University, did a study where they looked at biologic variation from patient to patient. Another person from Pennsylvania looked at it as a retrospective study. And with these studies, and we're not going to go into it today because this calculation causes me stress even trying to think about it, but you can work out this thing called, you can get these sort of, work out the index of individuality for results. So you use these calculations looking at biologic variation between individuals and analytical variation and between individuals to try and work out sort of the variation between different analytes. And you can see some here, even looking at the example of the potassium and chloride here. You know, you look at the potassium results, and they're all, even with different patients, with samples taken at different times, they sit within a reasonably close area on the reference interval, whereas the chlorides are more all over the place. So, you know, different analytes will behave differently. In Craig Ruau's study, they had 11 dogs that they had staff and student-owned animals that they collected multiple blood samples from. They had one person collecting the blood, they examined the animals every day, ensured they were healthy. So they took samples daily for a week, weekly for 6 weeks, and then a sample 3 months later. They were all collected in a standard way, processed in the same way, stored in the same way, and at the end of the whole collection period, a single sort of set of reagents, calibrators, and a single operator, and each panel was run twice. And it was things from a fairly standard chemistry panel that they looked at with that. So if you look at these analytes here, with the exception of maybe triglycerides, which we don't necessarily do routinely, all of these other things, you know, the liver enzymes, the bilirubin, renal values and things are all things that we would measure very commonly on our panels. So they worked out the index of individuality with in this study. So basically, if something was, if it had a low index of individuality, this is an analyte that is very adequately assessed by a population-based reference interval. If the result was higher, it's better done through an individual generated reference interval. So there were 3 analytes, glucose, triglycerides, and phosphate, theoretically to be best analysed by a population-based reference interval. The value should have been less than 0.7. Greater than 1.7 makes it better done individually. So these 3 were sort of in between, but probably reasonably adequately assessed by a population-based reference interval. All the other analytes, based on their index of individuality, it was determined that these were better analysed using individually based reference intervals. So the question comes with that. So for a lot of the chemistry values we do, you know, whilst the population-based reference intervals give us some idea, they are better looked at using an individual-based reference interval. So here would be an example of that, and I'm using VetConnect Plus to show it. So this is a dog, a 16-year-old dachshund. You can see, if you look across the screen here, you can see the sort of dates the samples were collected. So you can see this patient is a frequent flyer in this clinic, so lots of samples taken there over a period of time, and we can sort of line all these samples up with that. So, you know, the little beaker tells it was done, these samples were done in the reference laboratory rather than in-house, so we've got some consistency with those results. And I apologise, these are in the US units, but, you know, we can get the gist of things with that. So if you take this result in isolation, this is a dog whose creatinine is normal. So you'd think, well, great news, kidneys are looking okay. But then when we look at this dog over time, you would say, okay, here the creatinine is 1.5, it's all good. But if we look at this in trending it, these results, you can see that this 1.5 value, which we've got here, is the dog has been very stable with its creatinine for a period of time. And there's been a significant increase in the creatinine between these two measurements. You can see the next time the sample was collected, which was only not that long later, the dog had an elevated creatinine. So what this was telling us is that even though this sample here was within the reference interval, we had an indication that the dog's renal function was deteriorating. And keep in mind that and creatinine is one of the analytes that has been shown is pretty stable for an individual animal through their life. So if it starts going up significantly from what it has been over a period of time, even if that result is still within the reference interval, you need to pay attention to that. And George Lees, who's a veterinarian in the States who spent a good part of his professional life working on renal disease, it's shown with sort of research that up to a third of cats we see will develop renal failure in their lifetime or kidney disease, and 1 in 5 dogs. So potentially being able to show that earlier has value. So by trending those results and setting up that animal with an individually based reference interval allows us to do that. And obviously one of the challenges, I'll just go back one here, one of the challenges we face is, if you've got for many of your patients, you may have multiple results that you've collected from them over time, but they're buried in the medical record. And I know for me, even working in clinical practice, I didn't necessarily go back through the record to compare all those results over time. So by being able to use something like being able to look at these results in combination, using VetConnect Plus, if you're using your IDEX equipment, you can compare the reference laboratory and your in-house results. They all get put in together. We can actually use these results that you've collected over time, use them more effectively, to demonstrate things like this. And it's true for a lot of the liver enzymes and things like that as well. I'm going to just give you a quick little teaser here, since we've been talking about kidney disease. We've come to realise in sort of laboratory terms that trending serum creatinine really does improve its sensitivity over looking at just individual creatinine measurements. But if we look at trying to diagnose renal disease in patients, and these are very generic numbers, but you don't lose urine concentrating ability till you've lost about 66%, 2/3 of your renal function. Generally, a patient doesn't become azotemic till they've lost about 3/4 of their renal function. So the challenge in that situation is that we have lost, that patients are reasonably advanced in their renal disease before we diagnose it. There is going to be a new player in the market with that soon. A compound called SDMA, or symmetric dimethyl arginine. Now, arginine is an amino acid that's used in the nucleus of the cell as a building block of protein. When protein is produced in nucleated cells, it gets methylated. So we get different forms of arginine being produced. There's asymmetric dimethyl arginine, which is used as a sort of diagnostic marker in cardiac disease, and SDMA is produced. They found in human medicine a few years ago that SDMA, when that intranuclear protein is degraded, the SDMA is released into circulation, and it's almost exclusively excreted in the urine. So this compound has been shown to be very closely correlated to glomerular filtration rate, and more closely related to that than serum creatinine. So as GFR drops, the SDMA will go up. It's been shown that it's a good renal biomarker. It really only changes with renal disease. It's not affected by liver disease or heart disease or things like that. Correlates well with the GFR and the creatinine. And it's also, we talked before about things like creatinine being affected by lean body mass. So as your lean body mass drops, so will your creatinine, so can reduce its sensitivity for diagnosing renal disease, whereas the STMA has been shown in a number of studies to not be affected by lean body mass in cats and dogs. And on average, STMA will be increased when you lose 40% of your renal function. So this is potentially going to be a very useful tool in practice in the future, and something that's going to be available at some stage next year with that. So just briefly touching on VetConnect Plus here. So using that as a tool in your practice to, as we said before, use the laboratory results in a patient's history more effectively. So as I showed you before, it can be useful for trending, to show are things changing over time. It can also be a really useful tool with your clients, showing them that rather than, people spending money on clinical pathology and they don't necessarily see results, or they're just sort of buried in a record, being able to show this, and this will work sort of on any computer where you've got web access or iPad or things like that. You can show them all these results together, show that you've got a sort of library of results for their patient. You can show them trending. You can email them results from within the system, so you don't necessarily need to print out results. If their pet comes in the morning, that's having a surgical procedure, you do a pre-anaesthetic screen, you can email them the results from the system through the day and say, hey, great news, we've got, the pre-anaesthetic blood results were normal, we're good to press on with the procedure. It can be useful for sharing results with colleagues or emergency clinics or things like that. You can even, use it, we can collaborate to share results with another practice. So, for example, if you've referred a patient to a specialist hospital, I can tell you it's also very useful for me in the work I do of being able to see results rather than if people have done in-house results. It's very nice for me to be able to see those if I'm talking to people. If you use that example of creatinine, being able to show somebody that their pet's creatinine has been stable for a period of time and is now going up, that even though the result is still within the reference interval, the fact that that value is going up is telling us that something's happening with their kidneys, and it gives them something a bit more visual to say, okay, things are changing with your pet's kidneys. We really should do some more investigation, so potentially, doing a urinalysis, which ideally we should be doing all the time with when we're assessing kidney function. Maybe doing a urine culture, maybe checking their blood pressure, maybe doing an abdominal ultrasound. Even taking a step back to the STMA, one of the questions is, well, if we're diagnosing renal failure early at like 40% loss of kidney function, what do you do with that anyway? Are we necessarily going to use a diet in that situation? Maybe not. But having that, evidence that they're getting renal disease earlier can give us help by saying, okay, well, maybe we will do some investigation to see if we can find out why their renal function is deteriorating. We maybe will be more careful about drugs we choose, not using drugs that can have an adverse effect on renal function. If that patient is coming in to have an anaesthetic procedure, we'll make sure that we have them on fluids, that we monitor their blood pressure, to try and minimise further damage to their kidneys. So I've talked to you quite a bit about generating or about the value of an individual reference interval for a patient. The question is, how do you generate this reference interval, and how many tests do we need to do that? What I would say to you is we don't necessarily need a whole lot of results with that. So ideally, by the time a patient is 6 years old, it's ideal to have 2 or 3 sets of results when they're healthy during that time. So it doesn't necessarily mean that you need to be trying to sell the client on a whole lot of testing, but doing some wellness testing. Maybe if you've done some pre-anaesthetic screening, they can all go towards generating that reference interval. What I would say to you is, if you do pre-anaesthetic screening spaying or castrating when they're sort of 4 or 6 months old, those results are not helpful in generating this individual-based reference interval. You ideally need to do it once they're at least 12 months of age with that. So that pre-anaesthetic screening when they're young still has value for that actual procedure, but is not useful for theirs. So what are we going to do? How are we going to generate this reference interval? Do we need to particularly say to the client, oh, well, we need to be doing some tests to generate this? Well, not necessarily. You know, if you're doing a procedure on a patient that's healthy, like maybe it's having a lump removed or it's having a dental done, you know, that pre-anesthetic screen that you're doing not only has value for that procedure, but it's also giving you value for the future by helping you sort of generate that reference interval. Wellness testing, you know, if you're doing it every couple of years or even in a younger patient, you know, it's a way of sort of trying to telling it to the client sounds bad, but you know, you can sort of discuss the value of that with the client, that it's not only useful now to maybe try and detect some illnesses earlier, but it's going to help sort of give us that bank of results to help set up that individual reference interval for their pet that's then going to be useful for us in the future. So just sort of spending a few minutes on pre-anesthetic testing towards the end of the presentation here. And I know that it is something, you know, that certainly in me speaking to some clients about it, or having been at conferences and things, you know, it is something that for some folks is more controversial. You know, some people feel that they're overselling if they're doing pre-anesthetic testing. And I suppose for me, the thing is, if we're doing pre-anesthetic testing on healthy patients, we are going to get plenty of normal results. But it's sort of one funny thing I see with sort of having taught sort of a lot of students and residents and interns over the years and having interacted with a lot of veterinarians, we seem to have this funny attitude in veterinary medicine of like, you'll do a pre-anesthetic screen and some people come to the client and go, oh, sorry, it was normal, as if they feel like they've wasted the client's money if they do a pre-anesthetic screen and it's normal. Whereas my attitude is, great news, it was normal. You know, yes, you've spent some money on it, but isn't it good that we know that that the results are normal? And yes, it doesn't necessarily mean that there's no risk with an anaesthetic if it's normal, but you know, we can potentially detect things earlier that might affect the way we manage them in anesthesia. And obviously one thing that I would emphasise to you is that, you know, there's more to pre-anesthetic testing than just doing blood tests. You know, a history and a good physical examination are an essential part of a pre-anesthetic screen. Now, looking at the pre-anesthetic testing, you know, there's not necessarily a huge amount of the literature out there to say, look, this is, you know, that you're necessarily going to find things. But, you know, I'll give you a few examples here. You know, I'm sure most of you are aware of the sort of Banfield group in the States, large number of clinics, large number of clients. And, you know, they did a review over a period of time and looked with sort of a large number of procedures. You can see there that 9% of those patients had abnormal results. And of that 9%, you know, nearly 80% there was just one change. You know, 16% had more than 2 abnormalities, and a smaller number had 3 or more. The question with this is they didn't really look at this to say, did it affect the anaesthetics or not? But, you know, just looking at the number of abnormalities you get, keeping in mind that sometimes some of these may not be significant. There was a study in the Canadian Vet Journal in 2012 where they looked at a group of healthy golden retrievers, 53 of them, and did testing on those with the CBC chemistry and a urinalysis. On that, 54.7% of those dogs had changes on some of those results. A few years ago, there was a study in the South African Veterinary Journal where they looked at 101 dogs where they did pre-anesthetic testing. 30% of those had new diagnoses based on the pre-anesthetic testing, and 13 of them had procedures delayed because there were significant changes on that pre-anesthetic screen. If we look at that, you know, I think people tend to be a lot more comfortable about doing chemistries on a pre-anesthetic screen, looking at those liver values and kidney values and glucose and things like that. And sometimes, there's that question of, what is the value of a CBC with that? And as I say, if you're doing CBCs as part of your pre-anesthetics, you're going to get quite a few normal ones in there. That's not necessarily a bad thing. And even things like, hematocrits tend to be fairly stable on patients during their lifespan. So, we've even got to pay attention to that, like we talked about the chemistries. If you've had a patient that's run at a hematocrit of, 45 to 48 most of its life, and then you do a pre-anesthetic screen and it's down at 38, yes, that's still within the reference interval, but that is a significant change for that patient. Another thing is that, looking at the value of a reticulocyte count with that. When people are using certain types of in-house equipment, ones that give you absolute reticulocyte counts, you will sometimes see patients that do have reticulocytosis with a normal hematocrit. You get it through our reference laboratory as well now too, because on dogs and cats, we give you a reticulocyte count on every single CBC that we run on dogs and cats. Now, they can be high just because it's physiologic. Animal got stressed, spleen contracted, the reticulocytes tend to hang out in the spleen while they're maturing, getting their iron stored or getting their iron supply, and the spleen contracts and they go into circulation. But a percentage of patients that have a normal hematocrit and increased retics either have low-grade hemorrhage or low-grade hemolysis. And, that is a marker of underlying disease. And if you investigate those further, you'll find something, and especially if it's a patient whose hematocrit has dropped over time, it's worth investigating. Certainly having worked in referral practice, I've also seen patients over time that didn't have a CBC done as part of a pre-an. They just had a PCV-TP and the chemistries. And saw a couple of dogs over the years that maybe had been having dentals. During the dental, the person was aware that they sort of bled a bit and wouldn't stop bleeding afterwards. And they got referred, and when I looked at them, they had a platelet count of like 30 or 40. Not low enough to make them bleed spontaneously, but certainly low enough to make them bleed if you're doing a surgical procedure with them. So there's worth some consideration of doing, hematology with your CBCs. Just want to finish up with running through a case example here of a patient I saw a few years ago when I was working at the Vet Specialist Centre. This was Coco, a little sort of 4 or 5 months old Shih Tzu Lhasa cross that the people had obtained from a pet shop. And the last thing that the person in the pet shop said to them as they were leaving is, "Oh, by the way, the dog had kennel cough. It's all good now." They took the dog home, and guess what? It started coughing. So they took the dog to their primary care veterinarian. Had a mild fever, inflamed tonsils, so they treated it with some antibiotics. Great news, dog improved on the antibiotics. But when the antibiotics finished, the signs came back. And at that stage, the cough recurred, dog had a little bit of vomiting, was treated with a fluoroquinolone, improved again, but when that medication finished, the cough recurred. So I used to have to do every third Saturday when I worked at this clinic in Sydney, so lots of people loved coming in on the Saturday because it was more convenient for them. So I saw this dog on a Saturday morning. Temperature was normal, a little tachycardic. It was this bright, happy, excitable puppy. Still had some deciduous teeth present, and you could really easily elicit a cough on this dog when you palpated his trachea. So I was thinking, yep, dog's got airway disease, probably has kennel cough. So counselled the owners that probably given the recurrence of signs, we should at least do some imaging with the dog. So let me take some thoracic radiographs. Bony structures were good, cardiac all that was fine, no signs of heart failure, but some signs of sort of bronchial disease with that, no obvious signs of tracheal collapse or anything. They didn't really want to do any more diagnostics at that point in time, so I put the dog on some doxycycline. Guess what? The dog did really well on the doxycycline. I treated it for 2 weeks, but as soon as I finished the doxycycline, the dog started coughing again. Okay. So as I said before, esophagus wasn't dilated. You know, a young dog that keeps coughing, you'd worry, could it have an underlying disease like megaesophagus and it's aspirating? Couldn't find any signs of that. So saw the dog a few weeks later, and the cough had come back. So said to the clients at that stage, we really do need to do some more investigation. So the plan was to get the dog back to do a bronchoscopy and a bronchoalveolar lavage on it. Saw the dog again the day of the procedure. It was normothermic. Everything was pretty good, other than the fact it had increased tracheal sensitivity. The owners horrified me. For those of you who know me, I'm such a medicine person. I'm not a surgeon. I was once cruelly described by a specialist surgeon at Washington State as committing surgery rather than performing it. And the client said to me when they dropped the dog off, "Oh, can you castrate him as well?" And I was like, "Oh no, can't do that. You know, it would be really rude to your referring veterinarian, you know, your primary care veterinarian for us to do that. Not really appropriate." And they said, "Oh, would you mind calling them and asking them?" So of course the vet said, "No, you can castrate if you want." So fortunately, I found one of the surgical interns who said they were happy to do the castration, you know, once I'd done the airway procedures. To be honest, I didn't quite. Bad for me to say this now, but I hadn't even quoted the client for doing any pre-anesthetic blood work. But I had a vet student working with me on a rotation at that stage, and they all said to me, "Oh, should we do some pre-anesthetic blood work?" My estimates were always fairly generous, so I was like, "Oh yeah, we've got enough wiggle room in the estimate. Go ahead, grab some blood. You can go and run it." So about 20 minutes later, he came back to me and said, "I'm just a little concerned by some of the results we've got." So the puppy is now like nearly 6 months old at this stage, so mildly anemic, and it's a non-regenerative anemia. So, you know, a little bit of concern of bone marrow disease. Is that primary? So, you know, something dysplastic or toxic or infectious, or is it secondary? So renal disease, chronic inflammation, or an endocrinopathy. Had a bit of a lymphocytosis, you know, that could be from antigenic stimulation because it's got this chronic inflammatory disease. Hypoadrenocorticism can cause that as well. You know, likely too young to have leukemia. The monocytosis would suggest a bit of inflammation, but nothing really dramatic there. The chemistries were more concerning. You can see there this dog's got a pretty significant azotemia. Now, this is a dog that was in good body condition, had a normal appetite. The owners weren't aware of it being polydipsic or polyuric. The rest of the chemistry was slightly mild hyponatremia, but otherwise looking pretty unspectacular. Collected urine from the dog, and much to my horror, the dog was isophenuric. The rest of the chemical and sediment analysis was pretty unspectacular. So called the owners and said, "Look, a little bit of a concern there with the kidneys," and suggested that they did an ultrasound. Now, this is the actual dog's ultrasound, and what we found when we did a renal ultrasound is that he had polycystic kidney disease. And this appeared to be a clinically healthy dog. Now, you know, we probably would have put the dog on fluids if we anaesthetised it. Maybe not if it was a short procedure. And, you know, the dog probably would have done okay. But sure you can all imagine the situation that if I had anaesthetised this dog, you know, I would have maybe gone home that night. Maybe the owners would have called me the next day and said, "Look, you know, he's not eating very well. He's a little off." It would have been like, "Oh, maybe it's the anaesthetic, give him a bit more time." Then they might have called me another day later saying, "Look, he's starting to vomit now." I would have gotten him back in. I would have done some bloods and would have found he's azotemic. Said to the clients, "I'm a little worried about his kidneys." You know, we ultimately would have found the same things that we did on the pre-anaesthetic screen. So it would always be that concern that this client, despite being told that it has a congenital renal disease and this was always going to be a risk for the dog, I'm pretty sure I would have been the person who I took my healthy puppy into the clinic. They anaesthetised him to do a simple procedure and he came out with kidney failure. And I talked to vets on the phone who have, you know, done anaesthetics without screening, and then they found this sort of things afterwards. And it's always that concern that you're going to have that, you know, that the client is going to see you as responsible for those things. So, in conclusion, you know, so what we've talked about today is the reference intervals, how they're generated, and looking at population-based versus individual reference intervals, and the fact that individual reference intervals for a lot of parameters have a lot of advantages. You know, your parameter testing not only has value for that procedure now, but also has value for later on in life for generating that individual reference interval. And the same for wellness testing. Has a role now to try and pick disease earlier on, but also is helping you set that reference interval for the future. So with that, and look, I just had to put in, here's another picture of my dogs. This actual photo means a lot to me because this, you know, I lived in the States, I got both the dogs while I was living over there. And I took this photo when I was slightly psychotic, about an hour. This was at a hotel at Los Angeles. This was about an hour before I had to drop them at the airport to be transported back to Australia and then go into quarantine. And I was losing my mind thinking they would die on the plane. So that photo is pretty important to me. So look, happy to take any questions now. I will just throw this up for you at the end. Next week, you know, this webinar is the first in a series of ones. Next week, Gary Turnbull is having a chat about dentistry in your practice and how you can use that as a business tool. So I will leave that up there for you so you can have a look with that. I'm happy to take any questions. I thank you for your attention with hanging with us through the webinar. I'm not quite sure now, Jeanette. I don't know if you can, if you want to come off mute and ask me a question on the phone, that's fine. Otherwise, I think you can probably ask a question through the thing. But Jeanette, you may need to refer those to me because I don't have the question tab on the screen I'm seeing.
Sure, I've got it here. So if anybody would like to write a question, I'm happy to read that to Graham.
You may just hear me taking a drink of water after that. Hopefully you're all still awake. Hopefully I didn't sort of bore you to tears with that. But yeah, please feel free if you've got any questions.
Yeah, I'm not seeing any come up at the moment.
People probably want to go and have their dinner, Jeanette, and go and spend some time with their families and have a bit of a rest.
Well, thank you everybody very much for coming, and thank you in particular, Graham, for spending your evening talking to us and sharing your expertise.
My pleasure.
There aren't any further questions, so I wish you all good night.
Sorry, we've just had a late question come in.
Oh, I beg your pardon. I can't see that here.
That's all right. I will have a look at them now. We have, okay, from Adam. What were those three analysts where population reference ranges were fine for?
That was glucose, triglycerides, and phosphate, and it was more that they were okay with population-based, still fine with individual, but you know they didn't quite fit into the better with a population-based reference interval, but were in the they're okay with either category.
Okay, and we've got one from Carolyn. We GA'd an apparently healthy young pup. Owner had declined pre-GA testing with a completely normal clinical exam and no murmur. Its 0-2 plummeted to 50%. On induction, we woke it without proceeding. After referral, it had tetralogy of Fallot. A PAS would have found it.
You know, I suppose on a routine chemistry, on your 6-point chemistry, you may not necessarily get any abnormalities with something like a tetralogy of Fallot. What you might find is something on your CBC, because with a tetralogy of Fallot, they can potentially, and I'm getting on a bit of thin ice here because I'm not a cardiologist, but they can have right to left shunting with that. So potentially you could have a patient that's a little hypoxemic. And you might find when you do a CBC on those that they have a higher hematocrit or red cell mass. potentially even
Okay.
getting a bit above reference range, and potentially more reticulocytes because they're hypoxemic. They're producing more erythropoietin to try and push their red cell mass up, so high hematocrit, to improve oxygen carrying capacity. But you won't necessarily find a specific change with that, but that might be something you would see with it.
Okay, and Carolyn has just mentioned again it had a PCV of 65%.
Yep, so that can be a clue. When animals with cardiac disease have got right to left shunting, or they're getting hypoxemic with it, often one of the hallmarks of that is you'll see an increasing red cell mass.
Okay, Alison, sorry I had to step out for this bit. The SDMA test, is it available now or not yet?
It is not available now. It will be available next year. Can I remember which reference laboratory is going to be providing that test? I think it might be IDEX, but that will be early next year.
Okay, and one last one from Steve. Hi Graham, when can we expect the new urine test to become available? Is it a blood or urine test?
It is a blood test, and will just be, so it'll be available probably in the first part of next year.
Okay, that's it. There's a few thank yous, so thank you, Graham.
My pleasure, guys. So hopefully you found it interesting. I apologise, as I say, I'm not a business person, but hopefully, have given you guys some strategies there of why some of this testing that might be considered as optional sometimes is actually a benefit for your business for improving, giving you better medical care with your clients. And that can help bond a client to your clinic of providing that higher standard of care for them. And then say using your lab results a bit better can also, being able to just demonstrate them and display them better and use them more appropriately can also be something really helpful for you with your clients. But with that, I'll let you all go and have some dinner and have a rest. So thank you very much.
Thank you, Graham.
Thank you.
Bye-bye.
Good night.